I counted you and Wayne coming in, but there were about 12 or 13 people that came in at once. So if I missed anyone, just they can speak up and let me know.
All right. Do you know if we have a quorum?
No, sir, because I only counted 2 of you.
Well, Wayne, it's you and me.
I will turn
So
it
we'll
over
get
to you.
started. Okay. I guess we can't approve the minutes. We did receive those. Thank you. And is Pam on?
I'm here. Yep, I'm here.
Okay. Last time we had our meeting, you indicated that you'd be sending us some information that you described during the call, and I have not received that yet.
Yeah, I had some unexpected time out of the office, but I actually have, and Aaron, if you can let me share, I'm
great.
going to show you what I'm going to be sending you. I'm in the process of finalizing formatting so that it makes some sense. So the discontinuation notices, it's still, that one is very manual, and it's based on provider reporting. So I don't know that one I have not focused on. I focused more on the system generated reports, Rick, because I think that will give you all more information. So let me show you what I have, what we have done. So I gotta find, hold on, let me figure out where I bring it up so that I can share it. Okay, so this first one is a comparison of the, and let me see if it's coming.
I see something.
Table. Like it's, are you seeing, it looks like the Excel screen?
Yeah, it says procedure description, adult day training on the top.
Okay, so this is, so what we did, instead of comparing just July over the multiple years, we actually just did that first quarter of the state fiscal year. So this is July, August, and September. So you can see so it has, and it's ranked right now, it's displayed by the, based on quarter one, the total number, the highest total number of units. So this quarter one of 21 for adult day training, that number looks really, really low to me. So I'm looking into that right now to see if maybe it was a billing. I'm going back to see the dates of service that have been billed, because that number just is so different than where we have been. So I'm looking into that one a little bit more. But you also see then the total amount that was paid for each of the codes. So, you'll see, like adult day training, we really didn't see, based on July of each, or July, August, and September of each of those years, there's really not a, we didn't see a trend down in the number of units. Most of the codes or most of the services, if you look across, are like that. Now, respite, we did have a little bit of a decrease, but everything else, supported employment, and raised just a little bit. But all of your other services really either maintained stable, or they raised from each quarter of the year. Now, when you get down to specialized medical equipment down, these are services that are just, they're not utilized as much. So, the numbers are significantly lower. But that is more based on, it's not based on COVID or based on any other outside factors other than just the fact that they normally are not utilized extensively. And even the amount of utilization stayed relatively stable. You did have kind of an increase in the tech assisted residential, and you had a little bit of a decrease in community guide. That one, again, that one probably you could contribute to the pandemic and the fact that there were a lot of things closed in the community where they could not really access those services. So I'll send you this. I want to finalize formatting it, and so then I'll send this out to you also that you have it. But it does show you the number of units per the service, as well as the amount that was paid. Now, to go along with it,
Now,
Mhm.
when you look at the amount paid, I mean, I'm looking at the first quarter of 2001 and see, dramatic decreases in adult day training.
well, you have an increase until you get
For
to
example,
this quarter one, Rick, is lower, but your 18, 19, and 20 you had a trend, you went
okay.
up. It matched the units going up. I still, again, I'm looking into this quarter one 2021 to see. I want to go back to the master claims listings to see. I feel like probably there's a billing lag there.
Well, I guess I'm just surprised to see when you look at the totals in terms of amount paid between 18, 19, 20, and 21. There doesn't seem to be much difference,
There's
even though
not.
COVID.
Right. And so there was a lot of adult day training centers that.
When I look at these, yeah.
Yeah, they became very.
I'm sorry. Go ahead.
Yeah, I mean, there was a lot of innovation. There was a lot of virtual. There was a lot of even when maybe meeting inside a building was not the best interest, or in more confined spaces where they went out into the community and there were meetings happening. There was like adult day training happening in parks. They were doing some. They really became innovative for how to provide the service.
Yeah, but I'm just looking at the amount paid for like 2020 and 2021, those first quarters, and it's a dramatic decrease in amount paid. And I see where let's see what the residential went up,
right?
From 20 to 25 million, but everything. I guess I'm just surprised that the overall amount paid didn't go down more. Just looking at these numbers above it.
Right. And I really think this quarter one of 21 for adult day training is an outlier. I really think that it's related to the billing practices, and that maybe that the billing had not, when we look at 18, 19, and 20, those are far enough back that, most of the billing has gotten in. Now, when we pulled this report, it was, it wasn't that far into fiscal year 21. So it's a combination of the billing lag and then the timing of the report. So I'll owe you some additional information on that. Okay. But I really think that's not, it doesn't truly reflect the utilization. It really is a timing of the report and a billing lag.
Okay. What about quarter two? I mean, this is all quarter one, right?
This is all
these statistics are for the first.
These are all, because this was, you had asked for a comparison of July across the years. And so because we had the data, we did the full quarter.
How hard would it be for you to come up with the second quarter results across the years?
We have the data, so I can go back. I can have my so you want to look at the second quarter?
Yeah, maybe then this discrepancy clears up. I don't know, but my goodness, it would seem to me that the expenditures went down because of COVID. I'm just the
data actually doesn't show that. Yeah, the data actually
no, it doesn't. It
does not show that, right?
That's a real head scratcher to me. Okay.
So and then
what else did we have? Yeah.
So what we did to go along with this, I actually have, so we have a breakdown of, so, you know, in each, this is across all providers. We actually have the breakdown by provider of the services that they provided, and the number of units that were billed and paid for each of those quarters.
Well, that's all interesting. You're going to send that all on to us?
Yes, I will. I will send that on to
Okay.
you.
Okay.
So that was the comparison across the quarters. And then we have, and I kind of had showed you all a preview of this the last time, but we have, so for each year, and this one we were able to go back, we actually have back to 2017, but we have information on, so the number of unique individuals. And so again, we're looking at fiscal year 2017. So there were 4,879 unique individuals that billed for at least one service. We have our top paid provider and their paid amount. And then, to no surprise, residential is going to be the top paid code. And that's that way across the board. So, but then we have, you know, again, what our average, we have the average amount paid across providers, the average amount paid for members, and then we have this maximum, we have the minimum and the maximum number. This minimum, you see this low amount when you have people either that their plan of care just had started at the beginning of the fiscal year, so there really wasn't time for them to have billed, or they were discharged soon after the start of the fiscal year. Then we also, again, we have the breakdown of what was billed, what was paid, and then the total number of how many unique individuals they billed for. And then I'm going to sort this so that it's in a order from the either the number of unique members or the number of, or what was paid by provider. But you have every provider that billed for SCL services in that quarter, and you have that same information for them.
And this is the quarter of 2018.
This actually is 27. This is actually fiscal year 2017. This is the full. Fiscal year. And so I have that for each. I have that's for 17, 18, 19, and 20.
Oh, the full fiscal years. Okay. Yes. Okay.
So you'll have that same, so you're going to have that same information where you're going to see, you know, the number of unique people that were served. You're going to see your top provider, and you're going to see across provider and across members what the average amount paid was, the minimum amount paid, and then what the maximum. So we had at least one member that for fiscal year 17, we paid $177,000, a little over that in services.
What did you say, like for one individual? What was that one?
That is, so at least one individual, that was the maximum amount paid.
And I see the average is 68.
Right, correct.
Is that surprise you, or that's?
No, I mean,
I guess that's
typical with what we've seen. So, you know, and we have that for, again, all
right. How does that compare to ICF average then?
I don't have that off the top of my head, but I can pull that. I can get that information. I don't have the we have that claims data. We have that claims data, so we can pull that. Now, the one difference that you have to remember is that, you know, ICF includes, you know, room and board, and includes other services that they get.
Sure.
That are not included in this dollar amount. So it's not an apples to apples comparison. But I have that, and I can provide that. I can provide that information to you. You know, again, diagnosis code is not going to be a surprise, because you know, we serve a very targeted population for SCL, and so it's, obviously intellectual disability is going to be your top diagnosis because that's the target population that is served.
Well, that is a lot of information. Now, we also asked information about 30-day discontinuation
Those are
notices.
the ones that is a very manual because it is not captured right now in the system. And so that is somebody literally is having to look at data, and we're limited by the fact of whether or not a provider reported that and when they reported it. And there's also, it gets a little more confusing because it's showing up when individuals, for example, an agency that is serving them closes or is bought out, those also show up in the those 30-day discharges. So, we're working on gathering that, but I don't know that it is as valuable as, we're looking at ways to start capturing that in the system so that it's more reliable and so that we have, we can capture the exact reason and time frames better. Right now it is, for example, you may see somebody, I looked at some where the individual, so they'd issued a 30-day discharge and the individual was continuing to be served, months later, but there hadn't been any other incidents or there hadn't been concerns or any other communication. So, you wonder, was there something going on that caused them to issue the 30-day discharge, but now has resolved and they're serving them, they're able to serve them without any problems. So there's a lot of kind of missing information behind those numbers. But
well,
I understand. Still working on that.
I understand they're difficult, but I think it's really important that, because this is kind of an issue we've been discussing for a long time. Providers feel that they can't provide the support needs of an individual, right? They can't support them, and then they have to continue services, which is a situation that I'm sure no one thinks is good. But wouldn't you agree it's worth
right? Right.
down
We
and
will.
finding to what extent we have a problem here?
Yes, and I do have, there are beaded staff that have been helping us try to pull that
Good.
information.
Good.
I see some, let me go to the chat real quick, Rick. I see some questions. So
go ahead. Yeah.
So do units allowed represent units authorized on the plan of care or units that were billed? So the units allowed are the actual, they would be the ones that are authorized on the plan of care. And most of those are identical because they, you typically do not have anybody that bills more than what they were authorized. And then Wayne, can we use the Q2 2020? We can. I do have that data. It specifically, the ask was for July, to use that as the first comparison, but we can go back and look at Q2 of 2020, which would, when actually it would be Q3. So September, October, November, December. So really you're going to want to look at Q3 and Q4 to capture the shutdown that happened in 2020. And then Amy, this is data is on the state fiscal year.
Well, there's as I say, an abundance of information here, and we all look forward to looking through it. And again, I'm glad you agree that looking at this discontinuation notice business and the length of service after that, and crisis hospitalizations, it's this TAC has a great interest in that, and I'm sure you do as well.
Right, I do, and I think it's important. It's just important to remember all the limitations of the data too, so that when we make any assumptions about what the results mean, that we remember the limitations of the data.
Right.
Other things that we're looking at is we're pulling the incident reports and trending them based on the categories to see if there was any if there's been any increase in any particular type of incident that was reported. Now that again, there's a little, it it takes a while because prior to 2020, most of the providers were faxing that in, so MWMA was not required to be used. So, you know, we're having to make sure that we're comparing and reporting apples to apples so that you don't have any wrong conclusions just because of the way the data was reported. So
yeah, and it would be interesting to see to what extent the COVID had on behaviors, you know, where people were not able
exactly,
to
right.
go to ADP and that sort of thing. I think that would be really interesting for all of us to see exactly that impact of COVID
We're also
on everyone, and maybe beyond, to see, well, to the extent we recover after COVID is over, you know,
correct.
or
Yes.
if there's lingering effects of COVID, you know, I think would be fascinating.
We're comparing to the number of requests for exceptional supports pre-COVID and post-COVID, and then now as we're coming out of COVID, we're also comparing that information as well to see if we had, you know, if there was an increase in requests for exceptional supports, and if there was that a certain type? So we also are comparing that. Now, we're not seeing a lot of residential because, you know, obviously there was the ability to bill that increased rate through COVID without having exceptional support. So we haven't really seen a lot with residential, but we're looking particularly at, you know, like personal assistance and some of the consultative clinical, some of those services to see if there is if there was an increase, decrease, essentially what happened between pre-COVID, COVID, and now as we're starting to kind of come out of COVID, what does exceptional supports look like?
That's perfect. I think that will be very helpful. And I'd be surprised if there wasn't some lingering impact of COVID. You know, you look at just reading articles about kids coming back to college, you know, that they're not as motivated.
But, you know, I mean, it really has had a,
you know, that there's
lasting impact.
You know, there's this lingering impact on people's behavior. Yeah,
right.
Yeah. Well, good. Well, we look forward to that. And so this is sort of an ongoing project then, isn't it, Pam?
It is,
for a while.
I mean, it's a lot of data. So I will get this first batch out to you, and then we'll go back and modify the timeframes so that you have it's a reflection of actually the shutdown period of the ADTs, and get that to compare that as well.
I don't know if there's any more comments. I don't see those on my little iPhone screen here, but
Aaron,
are there any other comments, Pam?
And Aaron, can you help me to see if we have any raised hands? I can't, with sharing, I can't see if we have any raised hands or.
I don't see any raised hands.
Okay, good. So we can go on to the new business then. I understand there's some new information about the Appendix K summary.
My apologies. It looked like Barbara has her hand up.
Okay.
Sorry, Barbara. I missed that a moment ago.
Is Barbara there? Okay.
Sorry.
Well, is that you, Barbara?
Yes, I didn't aim to raise my hand. Sorry.
Oh, okay. Okay. Sorry. Okay. Appendix K summary. Anything that we should know about that? Recent developments?
I guess I would ask if there's, so essentially, you know, what was allowed in Appendix K this last time is the ability for providers to bill for a specific list of services. They could complete an attestation form and bill 50%. So an increase of 50% on the rate, but there had to be, you know, 85% of that has to be passed on to the direct service worker. And we've received oh gosh, I just asked for that count this morning and now I think we had logged a little over 100 of those attestations to
Mhm.
this point. Providers are able to go back and bill that back to January 1st. So we're working with providers that have already billed on either doing adjustments or if they need to void any claims and modify the PA. So we continue to work with providers on that. There also was a ability for ADTs and ADHCs to get a retainer payment. We have not received as many of those requests yet. I don't have the exact number, but it was less than 20 the last count that I got. So we are continuing to work with those providers. And as we get those requests, then we have to there's some additional work with looking at revenue and units billed prior to COVID and in the most current time frame. So we're working with those providers that have requested that to get those issued. There were some relaxation in some of the qualifications that would allow expansion of case managers, as well as would allow individuals who may be in college right now or they're in the vocational program at like high school and are getting ready to graduate, but they obviously do not have a diploma yet. So we're looking at them being able to come out and already, you know, provide some services. So I think those are the biggest changes that are in this current that were in the last approved version of Appendix K.
Well, could you go over what's meant by that retainer payment for adult day training? Explain what that is.
So that is, so if there is a, and I don't have the percentage of loss in front of me, but if there was pre-COVID to and I don't believe we used the most current, I believe we used, I don't have the quarter in front of me, Rick. I can get that and send that to you. But
That'd
it's a
be great.
comparison. Yeah, it's a comparison. And if there was greater than a X% of loss, then they're eligible to receive up to 3 retainer payments based on what the attendance was pre-COVID. So
Okay.
that they can use to, you know, pay for, you know, because a lot of the adult days and the ADTs, even if there weren't as many people coming or they were closed during that time period, you know, they still had to pay rent and utilities. And there were modifications that they had to make, you know, to buildings to comply with, you know, increased infection control policies. So it allows them to recoup some of the money that they had to spend that they weren't necessarily getting in reimbursement because they served less people.
Well, if you'd send out information on that too, that'd be great. Okay.
Pam, Amy has her hand raised as
Okay.
well.
Maybe it's already been provided to it, but I don't remember it. But anyway,
It's in that attestation,
that would be helpful.
attestation
Oh,
letter. Yeah, so I'll get that. I can we'll send that to you, Rick, because it outlines it in that form. So I'll get that to you.
Hey Pam, it's Amy. How are you?
I'm fine. How are you?
Good. I had one comment about the retainer payments, and then I have 2 clarification questions for you.
Okay.
So just my comment, this is just FYI for your own information. What I'm hearing from providers about the retainer payments is that they feel as though they're unable to take advantage of them because the revenue loss threshold was set at 50%. And the quarters were defined as the last quarter of 2021 and the last quarter of 2019. So if it's possible, if that 50% threshold is a hard figure, if it would be possible for them to maybe pick their own quarter sometime in 2021, because folks experience spikes at different times, right? Like in their programs where attendance definitely did drop below that 50%, but it may not have been in December. Does that make sense?
Mhm.
Yeah, we have to, I can absolutely go back and check that. I will say that we worked with CMS specifically on that language based on what
Okay.
they had approved for other states.
Okay.
But yeah, I mean, I can, and if providers will, express that to us through, either public comment or
Okay, yeah.
other various ways that they can get a hold of us. So,
Okay.
and I know there also was language in there about the, and I did have a question about this, because they have to report any like small business loans, or if they received any of the, the federal dollars. I did have one provider say, that their center has a myriad of services, some for Medicaid individuals, some for not Medicaid individuals. And so, we had directed them that if they, to clarify that in the response to us, that, if they'd had a small business loan, but it was used for, their private side of the house, or it was used for, these specific
Yeah.
services, to make sure they included that. And that doesn't necessarily preclude them from applying. We just need some level of detail around that.
Awesome. And I will reiterate that as well. And I will have folks who feel like they may otherwise qualify for the retainer payment, except for maybe, just a couple of the issues we mentioned, just email the public comment so that you have that on record. Does that work?
Yeah, that's fine.
Okay.
I would have them go ahead and fill out that form,
Okay.
but include that in when they send it. That way they've already done the form, so that part's already done. But just include that additional detail.
Okay. Yeah, no, I can do that.
Yeah.
And then the two clarification questions are about the update to the FAQ that was released, I guess, Friday or yesterday. I can't keep track of my days. But in it, you revised two questions of note. The number one was under the wage pass-through section, and it's the question about, can I pass along to, management staff? And you revised your answer to say, provider agencies should be sure to, it says the 85% can only be passed along to direct service workers. The remaining 15% can be used at the agency's discretion, for other staff.
Right.
But you removed, in that description, you removed language that indicated that the pass-through may only be for direct service workers providing the services eligible for the increase. Was
Right.
that intentional?
It was, because we went back and looked at that, because there are workers that we had. This came out of a lot of questions we were getting from providers that were like, okay, my staff that work at ADT also are providing residential sometimes, or also are providing personal care. And it is overly burdensome to try to figure out, okay, you get a wage increase here, you don't here. So they can, and that 50% increase is really intended to stabilize the direct services workforce. So yes, so it was intentional to remove.
So they can, so just to be clear, they can spread it across any direct service worker, even if they're providing even if that worker works in a service that's not subject to the increase.
Yes, they can choose to do that if it is needed to if it is being used to stabilize their workforce.
Awesome. That has been very highly requested. So I just want to make sure.
Yeah, we went back, and when we looked at that and really looked at some of the questions that we were getting, we determined that it was too burdensome, and it really wasn't. It didn't meet the intent of what it was to do, which was to stabilize the workforce in general that is providing direct care services to individuals.
Thank you. And thank you so much for that revision. And then the second clarification I have is about the question under the pass-through about past raises, if you raised your wages in the past. And originally that had a January 1st date tied to it, and that January 1st was removed. And so was your intention that if a wage increase was given, say like in November of last year, that would be applicable to count?
They just need to be able to document that they did.
Okay. Perfect.
So they, again, we went back and looked at the fact that a lot of providers did increase their wages back farther. Now they're not going to be able to bill us the increase 50% beyond, back or before January 1st, but they can use that if they had already done that. They can use that as their documentation that yes, they wouldn't have to increase the wages again just because they now are able to bill for it.
Yeah, awesome. Thank you. Thank you for that. Those things were like the most requested clarifications or comments that I have gotten. So really appreciate you all responding to that feedback.
And I believe if we have not sent it out already, it is coming out. We've been working with providers specifically on the residential component with specific directions about what to do if services have already been billed, and when you need to do a modification versus and when you need to void, when the provider needs to void claims, and working very hard with the providers to do things quickly and in an order that keeps the residential provider from maybe if they had to void, say they were voiding claims that had been paid from January to May, that's a lot of money to void without being able to immediately rebill the new rate. So we've been working very intently with providers on getting that done in a timely manner so that they don't have those gaps.
Yes, and I appreciate that. And I just wanted to say on a personal note, I was speaking with the case manager who had that situation that you worked directly with, and you stepping in was so greatly appreciated in that situation. So just thank you for that.
Well, and we're working with our staff too. I just reviewed a kind of a help guide for our staff that gives them a little more detail, because this is something different, right, for all of us. It's not something we normally do on a large scale. It was a kind of a onesie twosie thing that maybe happened in the past based on specific circumstances. So this has been kind of a learning curve across the board. So we, have been working with staff and providing some additional resources and education for them and answering questions. So I think it's going to kind of smooth out. It just was confusing in the beginning.
That's all I have, but thank you again. Just thank you so much for really working on that residential billing piece and for those two clarifications in the FAQs. Those will really help a lot of people.
Yes, thank you, Pam. And if I understand you correctly, you're going to look and see if providers can have some flexibility in which quarters they do for comparison purposes.
I will look at that. So I just need the providers to send me the information. So if they will, as I told Amy, go ahead and fill out the form, because that just puts the provider, that's just one step ahead of at least have that part done, but include that information when you submit it so that we can look into that and review it. It may require a modification to Appendix K. I'll reach out to my CMS contact that helps, that has been our Appendix K liaison to find out how much leeway we have there, or if I would need to submit a modification to that language.
Is there anything to report on the federal state of emergency?
Other than, it did get extended. Right now we're looking at our 6 months would be up in January. Your guess is as good as mine as to what's going to happen, is in July, whether it will be, I think, it'll be based on the state of where we are at that point. If there's been any other variants, if there been, what the state of affairs, if you will, what it looks like in July. But as of right now, it goes through mid-July, which means our Appendix K, those changes are in effect until January. Now, we'll start working with providers towards the end of the year so that we don't have, that it's not everybody all at once in a panic of, okay, now I have to revert back. We also are looking at, as part of with rate study, there'll have to be modifications done to the regulations. So we are working on what does the unwinding of our Appendix K look like? Are there flexibilities that we want to continue, but will require us to update the regulations? So we are looking at all of that right now and, developing our plan and for how we can try to have as seamless of a transition as possible for those flexibilities that we decide to make permanent.
Okay, that leads to our next item. So you think there might be some considerations with the rate increase with the state of emergency?
Well, so rate study and the flexibilities through Appendix K are really independent of each other.
Okay.
But we do know that with the rate study that, based on previously where we were going with the rate study, we know there are going to have to be regulation updates because we know there are rates that are going to have to be increased. I mean, there were some based on previous data that were, greater than 50% increase. I think there was a couple services that it was even 100% increase for that rate to be equitable and to really pay for the service and what goes into that service. So we know that there are going to have to be updates. And so we're trying to do the regulation updates all at one time because it'll make the process go smoother. And it should speed up the process because you're not going to get bogged down in having a public comment period and a rate, all of that twice for the regulation. So we're trying to stage all of that to happen at the same time.
But come July 1, there will be a rate increase as
the House Bill 1 rate increase is dependent on CMS approval because it was directed to use the ARPA funds. That requires a revised narrative and spending plan. And we submitted our update with some details in it and have had initial conversations with CMS, but are waiting for final conversations and discussion for whether or not CMS will approve that. They have said before that without a payment methodology and the validated payment methodology that they would not allow increases or they would not allow the spending plan, that money from ARPA to be used for rate increases. So we right now are in the phase where we're waiting on CMS approval of that. I will say that if CMS approves that and those rates do increase, then all of the other activities outside of rate study will be permanently suspended because we will not have money to do any of the other activities that were outlined in the ARPA spending plan, because that will take all of the money to fund those rate increases over the two-year span.
Yeah, that was my other. So are you saying then that if CMA approves these rate increases, you're going to suspend the rate study?
No, the rate study will continue because that is something that is required by CMS. They have told us we have to have that rate study done, but anything to do with looking at wait list, anything to do with looking at a children's waiver, everything else that was in that support spending plan and had been approved by CMS will no longer be able to happen.
Right. Well, I did have some conversation with or communication with Ralph Lawler at CMS, and he seemed pretty positive about all states. So if they ask for a rate increase, I think they're generally always approved, but we'll see. So on reconciliation now, one of the things that the Commissioner Lee when she was given testimony before the budget subcommittee was the idea of rate inequities. I guess that's between SCL and Michelle P.
No, it's across the board. So let me give you an example
Yeah.
of that. So HCB case management is $100 a month. So with the 10% increase, that takes them up to $110 a month.
Mhm.
SCL case management is $375. It's three something. So that's going to take them up to close to 400 or over 400 for the exact same required services, the exact same required qualifications. So that's where we're talking about. It's amongst the different populations, the rate.
Oh, okay. Okay. I got you. So, so you're not, so there's not a feeling that there's some discrepancies between SCL and Michelle P.
There are some there too. I mean, there are some there too. There's differences between SCL and ABI. There is,
Yeah.
I mean, it's across the board. It's within the same populations and it's in different populations. And so, unfortunately, the message that sends is that individuals who have a physical disability who are aged do not deserve the same level of service that someone who has a brain injury or has an intellectual disability deserves. That is, unfortunately, the message that the participants are hearing. But as far as a reconciliation in the recommendations from rate study and House Bill 1, they're independent of each other. So the rate study is based on, the survey data, factual data about what it requires to provide the services, whereas the House Bill 1 was just a flat, just a 10%, well, 20 total over the 2 years. So they're very independent of each other. Most services based on the historic data from the rate study actually need significantly more than a 10% increase.
Hey, Pam, and can I comment on this too? I think exactly what you're saying. I think it was the desire of the legislature that this rate increase just be a first step in the process. And then once the rate study is finalized and, hopefully CMS sees that we're doing that in the process of finalizing that the rate study not only justifies the rate increases approved by the legislature, but also recommends, also provides the foundation that more increases are needed later. I think that's what the thinking there is. And I think based off what you've said and the data we've seen, that's something that could likely happen.
It could happen. I just need everyone to understand that if CMS does approve it, we will enact it, but that means that everything else in that spending plan, that cannot happen. So, we will not be able to look at the wait list. We will not need to be able to make technology improvements. We will not be able to expand crisis services. We will not be able to do anything else that was approved in that spending plan.
And I would,
Question about the rate study. If the rate study, let's say CMS does approve these rates, which again, I'm really hopeful that they do. And then the rate study comes in and justifies obviously even higher rates than what was granted by the legislature. The Cabinet for Health and Family Services would then have to prepare a budget ask for the next budget in 2 years to implement the rates suggested by the rate study, right?
We had counted for some of that based on historic utilization when we did the budget increase already, when we did our budget already. So we
have the money to pay for
that.
So if the rate study authorizes, like, let's say 50% rate increases for a bunch of services, you all have the money to just implement that?
I need to talk to Steve, but we did account for the rate increases with the rate study based on our historic utilization and what that would look like. So that was because we knew the rate study was upcoming and we knew what the rates look like and how inequitable they were. So that was something that was considered.
Awesome.
when we
That's
were
good
doing our
news.
That's really interesting. That's really good news, because I thought we'd have to wait till the next biennium, but that's welcome news. So how is the rate study coming along? What timeline?
The survey closed last week, no, at the end of, okay, so it closed on the 6th. We had a few stragglers come in at the beginning of last week, but we received about 183 responses, which actually is close to double what we received the first time. There was a good representation of all waivers across the the population, with the exception of Model 2. That, I believe, is because it's such a small number that is being served, and honestly, we are struggling to even find providers to serve those individuals with the rate that we're paying. And unfortunately, they were left out of the House Bill 1 rate increases. So they were excluded from the 10% increase over each year. So they don't even get that amount.
Would you say that again? I'm sorry.
The Model 2 providers,
Uh-huh.
so that's our ventilator dependent. So our most
Oh.
complex individuals, they were excluded from the House Bill 1 rate increases. They were not included.
Okay. I don't know if there's a need for general discussion, or is there any more comments that I didn't pick up or hand? Okay, good. If there's a need for general discussion, well, we don't have any recommendations to take to the MAC, correct? Among other things, we don't have a quorum. The next MAC meeting is the 26th. I believe I can attend that, and I suppose we'll just distill what we've talked about today, particularly the data that's being collected and the rate study. Is there anything else that we should particularly mention at the MAC meeting that anyone can think of? Okay. Our next meeting is July the 19th. And I do have a conflict, but I believe I'll still be able to participate using my cell phone from another location. Is there anything else?
Do you want the current wait list?
Oh, yeah, I'm sorry. Yes, please.
So,
Sorry.
For Michelle P, there are, oh, hold on, I don't have the number. Okay, here. I pulled up the wrong thing. We're at like 70. I'll get the actual numbers to you, but we were at a little over 7,600 individuals on the wait list. 68% are under the age of 21. And SCL, we're about 2,600 on the wait list right now. We have, I'm sorry, it's 20. Oh, here's my number. Sorry, the SCL is 2,966 on the wait list, none on emergency. We have Michelle P, I'm sorry, it's 7,762, with 68% of those being under the age of 21.
Okay, but you'll send that to us, right?
I'll send that to you in writing.
Yeah.
Yes, I'll send it to you in writing.
Right. And in addition to that, you're going to send us the units of service comparison.
Yeah, I'm going to send you those, the reports I showed you. I will send you what we have today, and then I've made note of the timeframes that you all would like to expand that to include.
Great. And you're also going to send us information on the retainer payment business?
Yes, I'll send you that. I'll send out that the form. It has most of the details in that form, but I will get that to you too as well, Rick.
Okay, that sounds great. It was a good meeting. Is there anything else? If not, we will adjourn. Thank you.
Everybody have a good day.
Bye.
Thanks, everybody.